people come.
So maybe I need to mute this. Okay.
You can for the moment, but there is no one there except the recording.
But hopefully you can still hear me on this.
No, if you muted.
It's muted, you mute your speaker.
I
The
think
microphone's too far.
I've muted the output rather than the
Yeah.
microphone.
Yeah, the
So
input
hopefully
is
it's
okay.
okay.
It's fine.
So we'll start letting in 1 minute and then.
And do we start at 5 past the hour?
Yeah, and you end 5 to.
Okay. I may end before that, if that's okay.
Yeah, for questions. That's that. Yeah.
Great.
That was the extreme limit.
Yeah. Nice. What are you studying?
Doing the MPhil in computer science.
Yeah.
And I'm actually working also on ECG and EEG. I'm looking at out of distribution usage of foundation models.
Okay.
So very interested in this lecture.
So looking at how generalizable they are beyond the training data.
Yeah, exactly.
Fantastic.
With Chile.
Well, wait, satirists.
Well, yeah, the whole.
Yeah. But I do very little.
Right.
They do the work.
I work mostly with a different signal, with the photoplethysmogram and some optical. And we just looked at out of distribution performance for that, and it's fascinating. Like looking at how it degrades depending on which training set we've used. So we find that some training sets lead to more generalizable performance than others.
Within the same signal.
Yeah. Yep.
With ECG.
No, so this is a different signal that we've been working with. So this is called the photoplethysmogram.
Oh yeah,
I teach two lectures and they know about that.
Yeah.
And you were trying to generalize from PPG to what?
So we're staying with PPG,
Uh-huh.
but just moving from two external data sets that we haven't seen in training.
Interesting.
There's a word, are you familiar with the Clever's work, Dimitri's work on foundation model for PPG? Papagani, yeah. That's they know that word.
To this lecture.
Yeah.
Yeah, I'm intrigued. I'm keen to read up a little more on that one.
There's a paper from last month, very interesting, generalizing from EEG to PPG, and they were getting very good results on blood pressure estimation.
Okay.
And heart rate as well.
Okay.
From ETH.
Okay.
Yeah, there's a lot that's coming out now.
Yeah. Hard to stay on top, but like very interesting.
I really like the Nokia work.
Okay.
Because I like how, well, they know very well because I rave about that paper. I can because it's not my paper. They use a lot of data set, but also side the way they train. It's a contrastive learning approach that uses morphological features of the signal to find pairs that they can use to then make the model more general. And I've never seen features sequencing them using
Okay.
I think it's really
Fantastic. Okay.
yes, the theorist is working on some domain adaptation for this kind of signal. I can address this.
Very short.
Wait another 3 minutes. Should we start admitting? Hit some. I'll do that.
Yeah. That's gonna be really cool. I actually don't know the
It might be me and Eric and
Thank you.
Very good. Welcome everyone to this last lecture of the mobile health course, as well as the seminar for the mobile and wearable health seminar series. Our speaker today is Peter Charlton, who is a British Heart Foundation Research Fellow in the Department of Public Health and Primary Care in the University of Cambridge. I know of him because of all his work on biosignal and wearable data, and so I'm really excited about this talk today. Peter.
Thanks very much. Well, welcome everyone. Thank you for having me today, and welcome to those online as well. So today we're going to be looking at the ECG, electrocardiogram, and I'm going to be taking us on a journey through the development of wearable and mobile devices for ECG measurement. As mentioned, I'm in the Department of Public Health and Primary Care, so many of the areas that I share will relate primarily to clinical application of ECGs. Some disclosures. I've done consultancy work. Apologies.
It's okay. We have that recording.
And received plenty of travel expenses, for which I'm grateful. So cardiovascular disease in the UK. It's believed that there are approximately 170,000 deaths per year in the UK due to cardiovascular disease. And approximately 7.5 million people in a country of 60 or 70 million have cardiovascular disease. And it costs the UK healthcare system £12 billion to treat cardiovascular disease each year. So it's a reasonable problem to tackle. The ECG has been foundational to the assessment of heart function in clinical practice for many, many decades. Here we have the 12-lead ECG, which requires a bulky machine, it requires a trained operator, and is typically confined to clinical settings. To introduce myself, my name is Peter Charlton, and I'm a biomedical engineering researcher. I started my work here at St Thomas's Hospital in London, where I was tasked with taking the technology from bedside monitors on intensive care units out to the ward in the form of wearable devices. And for the past 5 years, I've been working in the Department of Public Health and Primary Care here at the University of Cambridge, where we've been looking at taking this technology further outside of hospital into the community in the form of wearable devices. And our hypothesis is that potentially wearable devices capable of measuring cardiovascular signals such as the ECG could help to identify the early signs of disease and therefore enable earlier treatment and prevention of serious health events. In today's talk, focusing on wearable electrocardiography, I will firstly introduce the ECG, and my intention is to provide an introduction from the beginning. So apologies, some of it will be the basics, but I hope to lay the foundations. Then I'll present some of our ongoing research into using wearable and mobile health devices to detect atrial fibrillation, a common heart arrhythmia that increases the risk of stroke. And finally, I'll just present a few thoughts on the potential future outlook for wearable ECG. So firstly, an introduction to the ECG. So what is the ECG? Electrocardiogram. Electricity, cardio, heart, and graph recording plotting. So it's a recording of the heart's electrical activity. And here we have a cross-section through the heart showing where the electrical impulses are conducted from the top right, which appears on the left-hand side, so top right anatomically, down to the bottom left, from the top of the atria down to the bottom of the ventricles. And an ECG looks something like this. So it's a recording over time of this electrical activity, the voltage caused by it. And the signal varies according to where we measure it. So for instance, if we measure the ECG between the right arm and the left leg, i.e. giving a vector which is in line with the dominant direction of the electrical impulse, then we get a lead 2 ECG, where you can see these nice, strong QRS complexes, waves indicating heartbeats. At the top, we have a lead 1. So this is going from the right arm to the left arm. And you can see here, the waves are much smaller, because this is only one component of that resultant vector. And then lead 3, the waves are in between lead 1 and lead 2 in this case. That's from the left arm down to the left leg. So a measure of the voltage difference between 2 points on the body's surface. I highly recommend this if anyone is interested in finding out more. And as our baseline, we will fast forward past the invention of the ECG, which is fascinating, involving the use of buckets of saline. And we'll start with the 12-lead ECG. So here we have expanded that same ECG. This is a printout of a 12-lead ECG, where now you can see on the left in blue what are called the limb leads. So these are the 3 leads that I just mentioned, 1, 2, and 3. And these are measured between pairs of electrodes attached to the surface, to the skin. Next, in red, we have the augmented limb leads. And these are measured slightly differently. They're measured between one of these 3 electrodes and then the average of the other 2. So in a way, they're derived, whether it's through analog or digital means. And then last, in black, we have the 6 chest leads. And these are actually illustrated, the position of the electrodes are illustrated somewhat in this picture. So you can see these 6 electrodes dotted around the rib cage. And so to get these signals, we take a measurement between one of these chest electrodes and then another average, this time the average of the 3 limb leads, which acts as our reference. So that's the 12-lead ECG, commonly used in clinical practice. Gives us a whole wealth of information via these 12 signals, which give us different views on the heart. So that's our baseline in the top left. Other approaches to monitoring the ECG. So next, moving along to the middle on the top row, we have a bedside monitor used in intensive care operating theatres to continuously monitor the ECG, can monitor multiple leads at any one go, perhaps 3, 5 leads, but not usually as many as 12. Then we have what's called a Holter monitor, named after Holter, who assisted with the development of wearable ECG, and comes in the form of what could be simplified to a chest patch. So here, this one only has 2 electrodes. It gives us 1 lead, and we can add on extra electrodes if we want more leads. And the idea there is that you can wear this device continuously for a day, a week, for 2 weeks. And we'll explore whether that's true or not in a few moments' time. Then moving on to consumer and mobile devices, we have the chest strap at the bottom left, available decades ago for sports enthusiasts to monitor their heart. Then a handheld device, developed probably in the last decade or so. This allows you to record a single lead 30-second ECG on demand. So this doesn't provide a continuous recording. And then very similar technology, this time in a smartwatch. So both the handheld device and the smartwatch have 2 electrodes, giving you a single lead. The smartwatch, just to explain, 1 electrode is on the bottom of the watch, so it's in contact with the wrist wearing the watch. And then the other electrode in this example is the rim on top, and you hold it with your opposite hand, which gives you a lead 1 effectively. The other thing that is helpful to know is that there's now a move towards synthesizing missing leads. So if you're using a device that doesn't capture all 12 leads, there's a question, can you synthesize the leads that you're missing? So for instance, the Cardia 12 lead synthesizes 4 additional leads beyond those which it measures or derives, which it says are similar but not identical to those provided by standard 12-lead device. And we'll explore the clinical implications of this later on. So you've recorded your ECG, how is it then clinically interpreted? Well, I'd suggest, and I'm prepared to be told otherwise, that in most settings, it consists of manual interpretation. That's the final step in the decision making. And often, to a lesser or greater extent, there is assistance from automated analysis. So, for instance, with a 12-lead ECG, these are usually manually interpreted with some assistance from the automated analysis. So earlier I didn't touch on this blue section of the printout, which provides the automated analysis. In this case, the analysis says it's abnormal, and I was told to go home and not come back very quickly because this ECG was completely normal. So not always the most reliable. Continuous ECG monitoring includes near real-time analysis, primarily to give heart rate and rhythm. So here you can see a heart rate of 91 beats per minute, and then typically monitors will provide alerts if they detect an abnormal heart rhythm. Holter monitor recordings, these are days or weeks, they're often interpreted manually, but often with assistance from automated analysis, such as identifying periods of an irregular rhythm, so that someone doesn't have to review the entire day or week's worth of signals, but instead can focus on those portions which might show some arrhythmia. And then moving over to the consumer domain, so portable device recordings often require manual interpretation to make a clinical decision, but are assisted through automated analysis, similarly to Holter monitoring, to identify those ECGs which might be abnormal that need clinical review. So, my key message here, ECGs are manually interpreted with some assistance from automated analysis. And there's a wide range of uses of the ECG in clinical practice, identifying signs of a heart attack, either historical or recent. So this is where blood flow stops to part of the heart muscle, or it decreases. Identifying arrhythmias, abnormal heart rhythms, and irregular heartbeat. Identifying structural heart disease, where the structure of the heart differs from normal. Identifying inflammation, so when either the heart muscle or the sac surrounding the heart is inflamed. And also used to determine whether drug treatments are appropriate and to guide them over time. More recently, there's been research into can you use an ECG not just to tell about someone's physiology here and now, but to predict what will happen to them in the future. So whether it's predicting the onset of an arrhythmia, such as paroxysmal atrial fibrillation, or whether it's to predict future health conditions, events more broadly in the years to come. If you're interested, I recommend this researcher's work. And so, because they're so helpful, ECGs are measured in a wide range of clinical settings. So here's just a short list of intensive care, theatre, emergency department, primary care, that's GP practices. But the list really does go on and on. They're very widely used. And of course, now that list could be extended to consumers measuring them themselves in daily life without being prompted by a clinician. So to summarize, the ECG is a measure of the heart's electrical activity. It's measured as the voltage difference between electrodes on the body surface. Different ECG leads are obtained from different points on the body. Several types of device can be used to measure the ECG, from single to 12-lead ECGs. They're often manually interpreted, assisted by automated analysis, and the ECG is widely used in clinical practice to identify heart problems. For the next section of this talk, I will present some of our work where we have focused on detecting atrial fibrillation, the most common sustained cardiac arrhythmia, which confers around a 5-fold increased risk of stroke if it's not treated. So it's believed that in England alone, if atrial fibrillation was adequately treated, then this would save 2,000 lives per year. It would prevent 7,000 strokes, and it would result in an additional 425,000 diagnoses. And just to explain this last figure, atrial fibrillation is often not recognized in routine clinical practice for a couple of reasons. Firstly, it can occur asymptomatically, i.e. without symptoms. So you might not have any reason to be tested for it. And then secondly, it can occur only infrequently rather than all the time. So if you have a test at one particular point in time, it may simply not be occurring at that particular time. So there's potential opportunity to identify this unrecognized atrial fibrillation and perhaps prevent the strokes that it leads to. And of course, wearable devices, which allow someone to record an ECG in daily life, may have a role to play. And also, we've been working with mobile devices, handheld ECG recorders, and in that case, giving them to people to use rather than relying on people to use their own device. And here, the target population is older adults. So typically those aged 65 or 70 and over. And this is because the incidence of atrial fibrillation increases dramatically with age. The target setting is in daily life rather than just in clinical settings, because AF can occur only infrequently. So you need to be looking for it for a prolonged period to try and catch most of it. And yet, smartwatch ownership appears to decrease with age. So relying on people to have their own devices, particularly in this age group, may not be the best approach. So we have been looking into the acceptability of wearable devices in this general age group. The idea being that potentially you could recommend that people are provided with a wearable device for a period of time to check for atrial fibrillation when they reach a certain age. And there are many different aspects to acceptability, and we've only been able to assess a few of these, which I'll comment on. So our work is not comprehensive, but gives some insights. And this all started 10 or 15 years ago at St. Thomas's Hospital, when we were looking at the feasibility of monitoring hospital patients continuously using wearable devices. So here, the rationale was that whilst you're staying in hospital, you're at risk of deterioration, your health deteriorating. And often there are early signs of this going to happen, shown in changes in physiology. So it might be worth monitoring people using wearables to detect these changes. So we monitored people firstly using bedside monitors after they had had heart surgery, major heart surgery. And then when they were ready to walk around and they were on a general ward, then we asked them to wear a wearable telemetry device. And in this study of over 200 subjects, with an age of around 60, 70, 80, we were able to obtain wearable data for around 3 or 4 days, a median value there. But what's really interesting is the percentage of time for which we were actually able to collect the signals. And here shown in blue, we have the entire data set on the left, and then critical care, that's when people are on a bedside monitor, and then for comparison, the ambulatory ward when people are wearing a wearable device. And you can see that when someone is lying down in bed, has a monitor attached to them with leads from this tethered monitor, we get a much higher percentage, approaching 80% ECG coverage, compared to on the ambulatory ward when we had 45% or so. And we thought that the reason that these devices weren't always accepted was because of people's level of motivation. So people may not see the reason for wearing these devices, see benefit to them, they may not be motivated to do it. When we came to formally assess this, we actually, we think we were wrong. And we think it was the effectiveness of the device that determined whether people were willing to wear it or not. So was it actually going to benefit them? And to illustrate this, we had one study participant who was wearing a device and wasn't that keen on it at the time, but nonetheless had carried on wearing it. And this patient suffered from a cardiac arrest early in the morning. And had he not been wearing this device, then it's not clear whether that would have been caught in time. And so days later, he then wore the device almost religiously because of the benefit that it had provided. Well, that's our interpretation. So that was a decade ago. And to come up to the present day, we're now running a study, this time in the community, called the Safer Wearable Study, where this time we're looking to assess the acceptability of these devices for screening for atrial fibrillation. Bear in mind that only 5% of people will have it, so the perceived benefit might be considerably lower. And we're specifically looking at older adults, so adults aged 70 and over. So in this study of 100 older adults aged 70 and over, they've all previously been screened for atrial fibrillation. And we've used this information to target invitations to a mix of those who do and don't have atrial fibrillation. We sent devices through the post, and instructions were provided via an instruction leaflet and also via a telephone call. And we asked people to try wearing these for a week. And the 3 devices that we asked people to wear are shown on the left. So we have one in the style of a smartwatch. This allows you to record a 30-second ECG on demand by placing your opposite hand on. The wristband in the middle doesn't capture the ECG, so I won't comment too much on that. That's just for heart rate monitoring. And then the bottom one is a chest patch, which gives a continuous ECG. We asked people to provide feedback on how they found wearing the devices through a questionnaire, and then also collected informal feedback through telephone calls. And the results that I'll present today are from the first 93 participants. Hopefully in a week or two's time, we might have results for all 100. So here are the characteristics of the participants. They have a median age of 78, sorry, a mean age of 78 years old. So they are older adults. Approximately a third of them have atrial fibrillation. And admittedly, there's limited diversity in this, this cohort, as shown by diversity in skin tone. So here at the bottom, there are 6 categories of skin tone on this measurement scale, and there are only participants from 3 of those 6. 92 out of the 93 participants filled out the questionnaire, and most of them answered most of the questions. And the questionnaire consisted of statements such as this. So if the chest patch was regularly used to check people's health, then I would be happy to wear it for a week. And you're asked to give a response ranging from strongly agree to neutral, neither agree or disagree, to strongly disagree. And most of these questions explored the effort required to use the devices. So I'll just present results from that particular domain. So 14 statements, each repeated for each of the 3 devices, and then 1 extra specifically on the chest patch. So the headline result is that most respondents say they would be happy to wear any device for a week. So the diagram shows in blue are those who agree or strongly agree, and then in red are those who disagree or strongly disagree. So you can see for the chest patch, the top one of these 3, 87% agree they'd be happy to wear it for a week. And then for the wrist-worn devices, this increased to the high 90s. And there was a non-significant trend towards preferring the wrist-worn devices over the chest patch. Some other insights. More participants agreed that the chest patch was uncomfortable compared to the watch, that the chest patch came off accidentally compared to the watch, and that the watch was easy to remove in comparison to the chest patch. And then when asked specifically about the electrodes, the sticky dots used to secure the chest patch to the chest, 19% of respondents said they were unacceptable. Much to my surprise, there's currently no significant difference in responses between female and male participants. So with that headline result in mind, if we then delve a bit deeper, we find almost a third of people report irritation to wearing the chest patch compared to 4 or 6% for the wrist-worn devices. And around 10% of people took the chest patch off early, which was often prompted by skin irritation. As an aside, the smartwatch-style device vibrates when it detects what it thinks is an irregular rhythm. That's via continuous photoplethysmography. And so a quarter of participants said they were disturbed in the night by it vibrating and asking them to take an ECG. Just to look at the ECGs measured using the watch. So participants were prompted to take an ECG 4 times a day, and in addition, when an irregular rhythm was detected. So we expect everyone to record around 28, 30-second ECGs. And the headline figure is at the bottom here. So people recorded a median of 33 ECGs, so more than the 28 we expected. And indeed, 91% of participants recorded at least 19 adequate quality ECGs, i.e. 2/3 of those which we'd expect, which is seen as kind of a mark of success. So this appears acceptable. So we have this dilemma. Most participants would be happy to wear any of these devices for a week, despite many of them reporting skin irritation. Perhaps there's perhaps a preference for wrist-worn devices, and most provided adequate data in terms of those 30-second ECGs from the smartwatch. Potentially, we could change the chest patch location, the electrode location, to try and improve acceptability further. And this is limited by being 1 week in duration. And we ask people to wear these devices simultaneously. So sometimes it's difficult to disentangle views on the separate devices. So next with this study, we will be investigating what influences how acceptable we find these devices. One of the areas of potential concern for wearable ECG acceptability, which has come up slightly in this study, is the potential adverse effects. So the concerns for patients wearing devices. And in another study, researchers have found higher levels of whether it's monitoring your own symptoms, being preoccupied with your health, having concerns over your treatment, asking for healthcare use, whether that's formal or informal, associated with those who wore a wearable. So there are potential concerns about the side effects, the unintended consequences of using wearables. So we've looked at the acceptability of devices. How do we measure these signals? And then once we have them, what do we do with them? So I'll focus primarily on the automated analysis, and then I'll comment briefly on the manual interpretation as well. So in the context of detecting atrial fibrillation, here we have a 30-second ECG, which has been manually interpreted as showing atrial fibrillation. And the typical process for analyzing this using traditional signal processing is to detect the individual heartbeats shown by these QRS complexes, to assess the heart rhythm, assessed from the interbeat intervals, these intervals between consecutive heartbeats, and also to look at the P waves. So here is an example of a P wave. So a P wave is this small wave that occurs before the much larger QRS complex. And this indicates the electrical activity in the atria. And in atrial fibrillation, it's this aspect of the electrical activity that is dysregulated. So this is a telltale sign. If you're missing this wave, then it's a good indicator of atrial fibrillation. And indeed, the two criteria for diagnosing atrial fibrillation from an ECG are no discernible repeating P waves and irregular interbeat intervals. And yet, there are some limitations to our ability to make this diagnosis from wearable ECGs, particularly those from the wrists or the hands. They're required using dry electrodes, which don't conduct as well as the gel electrodes used in clinical practice. They're recorded without clinical supervision, so perhaps the recording technique isn't quite up to standard. And this is a lead one ECG, i.e. approximately between the left and right arm. And just to return to our earlier observation, the waves typically are not as big in a lead one ECG as, for instance, a lead two ECG. So it's not the ideal lead for observing these waves. Nonetheless, that's what we have. So the first step in analyzing these ECGs, often to detect individual heartbeats. we were interested in how one should do this. What's the best approach to detect heartbeats in these signals? So we set out to identify the best performing open source QRS detector for use specifically with telehealth ECGs. We assessed the performance of 18 open source algorithms. We compared their beat detections against reference manual annotations of heartbeats on 6 datasets, 2 of which were telehealth datasets, and 1 of which was collected by our group, the Safer ECG dataset. And this dataset contains 479 ECGs collected during screening for atrial fibrillation. Here are the results, and I'll guide us through it using the colours, so hopefully it doesn't matter if you can't read the numbers. So what we have here are, on the x-axis, we have 4 of the 6 datasets. Each column is a dataset. And then on the y-axis, we have these 18 beat detection algorithms. And then the numbers indicate the F1 score, a measure of performance, where 1 is perfect performance and 0 is the worst performance. Blue corresponds to a high performance, red corresponds to a low performance. And so when using the criterion of the F1 score being 0.96 or greater, for determining whether an algorithm performed well, we find that 12 out of these 18 perform well on these ECGs collected under clinical supervision. If we then move on to telehealth ECGs, fewer performed well on telehealth ECGs. So only 5 perform well on this tele dataset, and only 6 perform well on the Safer dataset. And that's on high quality data from Safer. And if you look at lower quality signals, then the performance drops down considerably. So performance is much poorer on low quality telehealth data. So firstly, this is interesting because the performance from clinical settings is not guaranteed, far from it, when we move to wearable or mobile ECGs. Fortunately, performance remained high both in atrial fibrillation and in other rhythms, so that's helpful. And we were then able to identify what we suggest were the best performing beat detectors in this study, the UNSW and NeuroKit algorithms. Okay, so we've identified the best open source algorithm for detecting heartbeats. And the next stage is to extract interbeat intervals, RR intervals. And here we extended some previous work to develop an approach which consists of using one algorithm to detect heartbeats, and then using a second to try and predict whether or not you think they've been accurately detected. And the way we do this is we ask the question, do the beat detections from the second beat detector agree with those from the first beat detector? And for each beat-to-beat interval, if they do agree, then you predict that it will be accurate. If they don't agree, you predict it will be inaccurate. And we've reported results of this on one of those telehealth datasets, the tele dataset. And we found that when you investigate all the combinations of the 3 top performing beat detectors and then the 18 beat detectors as a secondary beat detector, then those 2 that perform best give the best performance for a low mean absolute error in the RR interval. So this is on the x-axis, and then deeming a high proportion of ECGs to be accurate. That's on the y-axis. So you're aiming for something in the top left corner. And although it's obvious in retrospect that if you use the best 2 algorithms, you would get the best performance, that wasn't immediately obvious. So we think this is helpful. The preprint on the subsequent work on Safer data will come out any day now. So once you've been able to accurately extract interbeat intervals, RR intervals, then you might want to classify, does this ECG show atrial fibrillation or not? And here's just an initial study we did to look at different approaches for analysing the characteristics of RR intervals statistically in order to try and classify as AF or not. So here we've used ECGs collected in a screening program, the Safer screening program being conducted here in Cambridge. And we've looked at 2,700 ECGs, of which approximately 700 showed AF, and then the remainder were non-AF. And here's a panel of 6 statistics quantifying the level of irregularity in beat-to-beat intervals. And we found that in all cases, the level of irregularity is higher in atrial fibrillation. The bottom right, I think, is inverted because that's the percentage of our intervals within 60 milliseconds of the median. So irregular corresponds to lower there. We're able to come up with what we think is the best performing metric. One could go off and combine multiple metrics to come up with an algorithm. And we hope to extend this work over larger data sets to understand what do interbeat intervals look like in atrial fibrillation and how can we detect it. There's a but. We need really high performance to use this approach in clinical practice. So just as an example, because atrial fibrillation has low prevalence, it's a highly imbalanced problem. Even if we have a tool that has high sensitivity and specificity, perhaps 95% for each, we might still only get a positive predictive value of 50%, meaning 2 ECGs would be sent for clinical review for every one that's found. So it's important to try and get the performance as high as possible. And just to illustrate that, so in the much larger, safer screening program, people have been asked to record ECGs at home using a mobile device. These are then automatically analysed to begin with and then sent for clinical review. And we recorded 162,000 ECGs from 2,000 participants in our initial feasibility study. And an automated algorithm was able to reduce that down to 11,000 ECGs for clinical review. So to dramatically reduce the proportion sent for review to less than 10% of those recorded. And yet, we still sent those 12,000 for review to identify the 48 participants who had atrial fibrillation. So there's great scope for using algorithms to accurately identify those ECGs which require clinical review to avoid the workload being too high. Finally, just a comment on manual diagnosis. In this same feasibility study, we were very fortunate. We had 2 cardiologists independently reviewing ECGs. So we were able to look at how well their diagnoses agreed. And we took 1,843 ECGs from 185 participants that were reviewed by both cardiologists, compared their diagnoses. And what we found were there were 44 participants for whom the 2 cardiologists agreed on the AF diagnosis. And then there were a further 31 for whom they completely disagreed. So one said they did have AF and one said they didn't. Here, I've ignored those where someone said they didn't know the answer. So rounding these numbers up, this means for every 100 agreed diagnoses, there would be 70 disagreements. Now, whilst this is a particularly challenging setting, this is after the automated analysis has excluded many participants from the review process. So these are the hardest ones to interpret. This does illustrate the level of reliability in diagnoses in this setting, and others have reported comparable results. And we found that the quality of the signal was the key determinant of the reliability of diagnosis. So just to finish, a few thoughts on the outlook for wearable and mobile ECG. We're now able to detect disease that we weren't able to detect before, so infrequent atrial fibrillation. And there are questions about whether that warrants the same treatment as that which has previously been detected routinely in clinical practice. Then it's important to think about how we integrate these tools into the clinical workflow. And I mentioned this device which synthesizes 4 ECG leads earlier. What I didn't show us was the remainder of this paragraph from the FDA approval, which is in bold, saying that these synthesized leads are not intended for diagnostic use. And so I have an open question in my mind, and I'm sure there are people who know the answer, as to how we incorporate these into the clinical workflow when they're not intended for diagnostic use. And we should keep the clinical workload in mind. So the goal of wearables might be to move from asynchronous care to continuous care, whilst minimizing the burden on patients, caregivers, and I would add, clinicians. And yet there's a real danger that we overload clinicians with data. Indeed, a recent publication said in which cardiologists in Wales were surveyed about the use of wearables amongst their patients. 92% of these using consumer wearable technology to diagnose either often or sometimes. So 92% of cardiologists use these devices. They receive new referrals prompted by these devices, and we need guidelines and pathways to understand how to make use of this to prevent what it terms unregulated backdoor to these devices. And just as a last thought from me on the use of AI for ECG interpretation, here are what I think are 3 helpful papers which provide compelling arguments to use AI. So the first, if AI-based models achieve similar or better diagnostic performance than clinicians, I think that provides a compelling argument to consider the use of AI models. The second, admittedly, perhaps it certainly doesn't use deep learning. I don't know if it uses machine learning. Suggests that if AI-based models can safely reduce the clinical workload, i.e. filter out that data which doesn't need to be reviewed by a clinician, then that's a suitable use case. And then the third, perhaps you could use AI to detect signs of asymptomatic disease that usually wouldn't be spotted, a little bit like atrial fibrillation, but even further in advance. And that would prompt further assessment. And I think that's a relatively safe use case, because in the more detailed assessment, then you will get a final answer. And just the little add-on I would make is, I'd really like to see these models have uncertainty quantification, a don't know class. And much of the research in this area provides a binary classification of yes or no. Does someone have a disease or not? So with that, I'd like to thank my colleagues, both here in Cambridge and elsewhere, and thank the institutions that I've worked with, the funders, and conclude by saying the ECG is and will remain fundamental for investigating heart conditions. It can now be measured using a range of clinical and consumer devices, opening new opportunities to detect disease and predict future health conditions. And if we want this to be as reliable as a climbing rope, then key areas for investigation include ensuring the acceptability of devices, minimizing the associated clinical workload, and ensuring the accuracy of manual and automated diagnoses. With that, I'd like to thank you for your attention and provide my email address in case you want to get in touch, and welcome any questions. Thank you.
Okay, see there are some questions for the audience online. Please add in the chat and we can read them. For the audience here, just raise your hand. Jake.
Thanks for the talk, Peter. It's really interesting. So about the atrial fibrillation, a friend of mine who works in a hospital has been moaning about a really high false positive rate from watches. So a lot of people come in really worried that they've got it, and he says nearly all the time he has to check them out, and it says no. What's kind of your opinion on this? Is it just something we have to accept, like a high false positive rate, or do you think it can be improved from these devices, or maybe not much of further research?
So I think I'm a perfectionist by nature, which often isn't very helpful. So I certainly wouldn't want to accept this. I would want to work further to try to improve the performance. And one key point just to highlight is it is possible for both the consumer watch and the clinician in that instance to be correct, in that perhaps someone did show atrial fibrillation previously when it was detected by the watch, and then they simply don't show it when they arrive in the hospital. But leaving that to one side, and I think there are 2 factors to consider. improving the performance of the devices, the automated analysis. And I think that's both hardware and software. So the quality of the signals provided and then the automated analysis. But then also how we integrate this into clinical workflows. Is it acceptable for someone to turn up with the output of any watch and for that then to prompt further assessment? Or do we put in place a process for deciding what to do in that case?
Right, thank you.
Building on that question, I think in one of the previous slides on atrial fibrillation, you said that 162,000 ECGs were recorded at home, and then 12,000 were identified for review, and only 687 ECGs actually required further manual exploration. Sorry. Does that mean that only around 6% of those ECGs actually contained something that the clinicians deemed necessary exploration?
So I think that was 687 showed atrial fibrillation, I hope. I can come back to the slide.
Yeah, if you don't mind. It was a lot.
Yeah, so we've been narrowing down from the 162,000 recorded to then on the far right, those that actually contain AF. And we found that 687 were found to contain AF.
Does that mean that 11,300 were false positives?
Yeah. There is a slight caveat. I'm not sure, I don't think all of those were reviewed.
Okay.
So this is a pragmatic study. So those are the numbers that were sent for review. For instance, if a cardiologist found someone with an ECG with AF, they wouldn't have continued to review the remaining ECGs because they could have made a diagnosis on the basis of that. But nonetheless, the figures below are helpful. ECGs were sent from 1,500 participants, only 48 of whom had AF. So there are clearly still a decent chunk of ECGs that don't show AF that were sent for review.
Excellent, thank you.
There's a question online about the fact that you collected a data set for your research and they're asking if it's publicly available, and they also missed your method. How did you analyze the ECG signal and did you use any AI?
Thanks very much for the question. So yes, the data set is on the way. So the Safer Wearables data set, we have obtained consent to share it, and we will do all the data that we can. How did we analyze them? So today I've presented results on acceptability. The next step is to assess the performance. How well do these work? And I will start myself with traditional signal processing methods, but I'm very fortunate to be part of a consortium who are looking at deep learning methods for this task. So perhaps between us, we will cover the different approaches for analysis.
Okay. I think there's another question, unless there's a question. Okay, but maybe take one in the audience, Yvonne.
Yeah, so I have a question is, do you know the current consumer watches, can they collect high quality ECGs? Like if they, because the Apple Watch can also do like atrial fibrillation, but sometimes you do not wear it in a good position or hold your hand in a good position, then there's like noisy in those ECG signal, and I'm not quite sure whether they can detect those R peaks missing in using their algorithms. So they don't know how.
It's a very important question. I don't know the ins and outs of every single device, so I won't comment on specific devices, but I'll give two illustrations. So firstly, this is data from our study with one particular device. And what I didn't highlight was that the number of complete ECGs is a median of 37. This is about 6 rows down. And then the number of complete adequate quality ECGs is 33. So there are some which aren't of adequate quality. And you're right to highlight that recording technique may be responsible for that. And then secondly, the process of using dry electrodes, there's some really helpful research illustrating that that can introduce filtering. So analog filtering via the components, which can filter out some of the important information from the ECG. So we have to be aware of the hardware in terms of whether that is enabling us to record all the essential aspects of the physiology, or actually whether we're only observing a subset of the physiology.
And do you assume whether we, like the software part, can help do something, I don't know, reconstruction from like a noisy missing data to reconstruct to like high quality like real ECG signal?
Yeah, so I'm sure it can help. And with other physiological signals, motion artifact removal has been hugely successful. I think the difficulty I have here is to what extent we allow reconstruction, because we want to ensure that there's no hallucination at the same time.
There is a question online. Considering all the challenges with wearable ECG that you mentioned, what should be the direction of technical progress in these devices? Do you think the increase in frequency of chest straps ECG, for example, to 4 kilohertz, could provide any advantages?
Briefly, no. So I think increasing the sampling rate to 4 kilohertz, as far as I know, won't help, because I think all the relevant frequency content is in much lower frequencies. And I think the most important direction for me, and I'm biased being in the Department of Public Health and Primary Care, is how do we use these devices clinically? We've had a question on this already. And then I didn't realise, as I was preparing for this, the BHF statistics, British Heart Foundation statistics, really illustrate the increased incidence of cardiovascular disease and events in lower socioeconomic areas of society. And if we're advocating the use of very expensive devices to detect disease, then that won't help everyone equally. So I think we have to think about equity and clinical integration as well as the technical sides.
Thank you. Okay, we are coming to the time, so I'll stop here. I'll thank you again and thank the audience. Thank you. All right, this concludes the talk. It also concludes the course for the few of you that have been in the course. It's been a pleasure to teach. Thank you very much.